Good afternoon, everybody. My name is David Andolfatto. I'm with the Federal Reserve Bank of St. Louis, and we're here today with Larry Jones, who's a professor of economics at the University of Minnesota. We're here at the St. Louis Fed's 38th Annual Policy Conference, and Larry's here presenting a paper that's titled, "Is There Too Much Inequality in Health Spending Across Income Groups?" And Larry's agreed to sit down with us to describe what he's been doing, what sort of questions he's asking, the type of answers he's getting, and why policymakers or the rest of us should be interested in general. Would you like to start off, Larry, by describing your work to us?
What we're trying to do is to come to a little bit better understanding. We felt we didn't know, have a good enough sense about what health spending should look like for the difference between rich people and poor people. So this problem is handled in different ways in different countries. In some countries, basically, rich and poor people get the same kind of health care coverage. Canada's the prime example. Many countries in Europe have this sort of dual system where pretty much everybody, most everybody, is enrolled in a sort of single-payer government-run system, but very wealthy people typically get better. They typically opt out of that system voluntarily and pay for additional higher quality care for themselves out of their own funds. In poor countries, basically, you're on your own. So this is handled in a lot of different ways in a lot of different countries. And in the U.S., this is sort of has had a unique system where mostly it's been handled through private insurance, through people's jobs for a large fraction of the population, with this system where a large fraction of the population, once they turned 65, reached retirement age, were covered by a government-provided, generally funded system. So we felt like we didn't have a good understanding of why these different systems exist at the same time. Is it true that in certain circumstances, one is the best system or a better system. In other circumstances, the other kinds are a better system. What is it that determines which one is a good system or a better system than the other? So we wanted to get some sort of idea about that. And in particular, since we're going through a big change in the U.S., a lot of the discussion about these systems has been about do people at the bottom of the income distribution get enough health care? Economists have sort of buzzwords that they use to describe these things. They describe something called the social safety net, which is a series of social programs which make sure that if you're particularly unlucky, that you don't get hit too hard. So there's different kinds of programs like food stamps, kinds of housing programs, some medical care programs like Medicaid for poor people. So we wanted to know kind of how big should that social safety net be on the medical care part. That's what we were interested in.
And so how does one go about trying to ascertain how much is the right amount for people?
Well, our approach was it's kind of two parts to the question. First is to ask how much is there. Mm-hmm. So like I said, some people seem to have this idea that there's no health care for poor people. That's just not true. Right. There are several different methods that it gets delivered, and maybe it's delivered well, or those systems are good or not. There's the Medicaid system, which some people are eligible for. There's also sort of the emergency room care system, which is you go up, something's wrong with you, you show up in an emergency room, they're required by law to treat you. Mm-hmm. Then there's some other issue about whether you pay for it or how it gets paid for, if it gets paid for at all. So the first thing is to sort of just get some idea about the magnitudes of the amount of money that system is spending currently. And so we looked through this data set analyzed this data set called the MEPS, M-E-P-S data set, Medical Expenditure Survey, panel survey, which collects data on individuals about how much is spent on their medical care and what it's for and what the source of funding for it is. What the source of funding for it is. So did they pay from it out of their own pocket? Did they have an insurance company pay for it? Did Medicaid pay for it? Did Medicare pay for it? So it's a rich data set which has a lot of information about medical expenditures. So that's the first thing, is to look in the data and see sort of what does this thing look like? How do medical expenditures differ for rich and poor people? And it turns out total expenditures don't differ that much for rich and poor people in the U.S. If you looked at the top 25% of the income distribution, relative to the bottom 25% of the income distribution, the ratio of total expenditures across those two groups is about 1.2. So one would say that it's the same. And I think most people would guess that it's much bigger than that. They would think it's like 3 or 5 or something. For example, if you look at other kinds of consumption expenditures, you get numbers like 5 or 7 for that
Wow.
ratio. So it's quite a bit less. So that tells you that there's quite a bit of insurance going on already in the U.S., even though it doesn't have a system like a formal system like Canada does. And it's quite a bit more than what people think. So that's the first thing. There's other issues about the way that money is being spent. For example, for poor people, a lot of the way they get medical care delivered is to go to the emergency room. And one of the things that people are concerned about when they're talking about changing the way the health care system in the U.S. works is the fact that you have to go, if you're poor, if you have to go to an emergency room in order to get medical care. Going to the emergency room is a miserable experience for anybody. It's a hassle. You have to wait a long time. So what people worry about is maybe people put off getting taken care of for too long, and so that when they do get treatment, they're in worse shape. So maybe if we had a system, a different kind of system, we could get them treated early, they would be healthier, and it would cost us less. So
Not enough preventative care.
Yeah, not enough preventative, more curative. So
Right.
that's the kind of thing that people talk about. But unfortunately, this data set, MAPS data set, doesn't have the distinction between preventive and curative kind of care. So
That's what you just reported about the differences in healthcare spending across income classes. That's quite astounding. I mean, did you control for, this is just the average person, but did you control for people of different ages or sex or other demographic characteristics?
yes, that's by, so that number depends on age.
Right.
And so we've done a conditional on age. So that number, but it's about the same until you get to post-retirement years. Then it goes up a little bit.
Okay.
So it doesn't depend that much on
That's
age.
quite fascinating. So that's the data part. And that's kind of, I think most people would find that a little surprising, actually, what you've just reported.
Yeah.
Now, you've also, in the paper, written down a theoretical model, as economists are prone to do, for the purpose of what exactly? Explain what that part is for.
Well, the next thing we want to do is get some sort of idea about, is 1.2 too big, too small? And that's a really difficult question. But that doesn't scare economists, right? I mean, so how do we handle it? You just make a bunch of outrageous assumptions and try to get a start at figuring out whether that number is sort of too big or too small. So we kind of know that not everybody can get the same health care. Everybody can't get treated as well as President Obama does, and I kind of know that I'm not going to get treated as well as he does, and we all sort of accept that. So some amount of inequality is acceptable. The reason, my take on the reason he gets treated better than me is he's more valuable than me in some sort of fundamental sense. The world would keep on working just fine if I didn't go to work tomorrow or if I got sick. It's much more difficult situation if he has some sort of serious medical problem.
No, you're too modest.
It's very nice of you to say. Not true, but very nice. So we try and use an economic model which takes into account that fact to sort of get some idea of what that difference, quote unquote, should be like.
Yeah, so I see here actually a line from your paper. You say, we show that under the efficient allocation, so under an efficient delivery of healthcare spending should increase with labor productivity. So more productive members of society should receive more healthcare.
Yeah.
Among other things, it prolongs their longevity, I suppose, and keeps them healthier. But that this recommendation that comes out as a byproduct of the assumptions your model makes says also that this should only be true during the working years, that once people retire, this is no longer the case, that everybody should more or less be treated equally.
It sort of captures exactly that idea that somehow President Obama's doing more important stuff than me, so we want to make sure that he gets to keep doing it. It's more important to make sure that he gets to keep doing it than I do. Now, that means maybe I'm going to be sick, or maybe I'm going to die younger than him. That kind of stuff is just part of that. But we sort of all accept that that's part of it. Once he's not doing anything important anymore, and I'm not doing anything important anymore, then that distinction goes away, and the model says we should get the same kind of healthcare.
In the theoretical approach, and I realize that this is, like you said, a first approach, but in reality, productivity differences might be a bit difficult to observe. It might have to be inferred indirectly by your salary, for example, which we know that in reality your salary might not fully reflect your productivity per se, but other factors. Is that a concern?
Sure. I guess I would say it's a little nuanced version of what you said, which is salary and wages are imperfect indicators of what some sort of underlying social productivity is. President Obama is also not the highest paid person in the country.
That's true.
So there are imperfections like that. So that is that means we inherit that imperfection. I don't think that means you shouldn't do it at all. It just means that you do this as a first cut, and if somebody comes along with something better, then I'm all for it.
Okay. So your theoretical setup kind of allows you to ascertain what a desirable allocation of healthcare spending should be in a society, and you try to match that up with the data to kind of evaluate?
We don't try to match it. We try to do what economists call a quantitative or calibrated version of that model to see what that 1.2 number, how does that compare to what we get out of what the model says we should get. And one of the things which is interesting is the model said it should be about 1.2. You know, it's not exact. But
so to a first approximation,
it's very close.
The allocation of healthcare spending in society, at least theoretically, according to this model, is pretty close to...
That's right.
So we have to be careful, though. I guess this is a statement about, this is not a statement about insurance or anything like this. I mean, the revisions to the way, or the Obamacare, the Affordable Care Act, does this have any repercussions? I mean, does your model have anything to say about that? Is it desirable in general?
It doesn't really say much about that, other than be a little bit careful, because it doesn't look like, to the extent that that law is directed at trying to get more health care to the lower part of the income distribution, it doesn't look like we need to do too much on that dimension. To the extent that it's to try and get to redistribute the payments for that care, maybe we could do some of that. Because of course one big part of the plan is and as you know, the Canadian plan, for example, is one part is the healthcare delivery part, another part is the payment part.
Right.
And let's just take Canada as an extreme. Roughly speaking, everybody gets the same healthcare coverage in Canada, but how much you pay is proportional to your income. And so that makes it a very unusual kind of good provision.
Right. So I guess what I was getting at was, so it could very well be the case that people, by and large, in America are getting the right level of health care at the end of the day, more or less. But that in some cases, those that are uninsured, those that lose their jobs, those that have pre-existing conditions, they lose their insurance. And if they have any assets, they might lose their house, for example, in the event they get sick. They'll still get their optimal amount of health care. It's just that they're going to lose their house. Your model doesn't speak to that that part.
No, and also the other thing which we mentioned, which we came up briefly before, that maybe because of those effects, they put off getting treated.
Right.
And that makes their health worse. It makes it more costly to cure them or improve their health once they actually do get treated.
Well, very
That's something which I think that's going to be hopefully one of the big benefits of the new system is if you're insured, then you don't wait until you have to go to the insurance, to the emergency room.
So just to wrap up, Larry, I guess if you had to, what's the takeaway? What would you provide us, 2 or 3 bullet points, the takeaway of your research that you're presenting here for our audience here?
First one would be there's already quite a bit of healthcare insurance provided in the U.S. under the current system for people that are needy. And because of that, maybe we want to be a little bit careful about exactly how far we try to push things when we're making policy changes. We should be informed about that stuff. And maybe what that first thing tells us is the focus should be on the delivery system, not kind of the overall quantity so much.
Very good. Thank you very much, Larry. Appreciate the time you're taking here.